Thank you, Amy. Appreciate that. And welcome everyone. We've got a really nice attendance for today's webinar series or final session of our four-part webinar series. Today we're going to talk a little bit about many different topics around compliance and really year in review, and looking forward to what some of the more significant things that we see as being important going forward. Just as a way of quick background, many of you I think have joined other sessions. Our firm has put on a webinar series around internal audit compliance the last several years. This is the fourth and final part in our four-part series for this year. At the end or after this session, we will be sending out some surveys, and we'd love for you to not only fill them out about this session, but if you have any thoughts or ideas on how we can improve upon it or topics that you'd like to see in the future, that would be great as well. With that, I think I'm going to kind of jump into the panel introduction real quick. First of all, I probably should introduce myself. I'm a partner, Scott is a partner in Minneapolis office. I head up our health system segment, and I also have a dual role, and I head up the internal audit service line for the firm. And I've been helping coordinate all these sessions. Today, really, I'm doing a very minor piece of this, and we've got really kind of a STEAM panel that are going to talk about a variety of issues around compliance. With that, I'll pass it over to Amy.
Thanks, Scott. I'm Amy Tepp, and I'm a partner. I'm also in the Minneapolis office. I oversee our revenue cycle services as well as the compliance and healthcare services for the firm. And I've been in healthcare my entire 30+ year career, primarily in the mid-cycle of the revenue cycle, as well as compliance. I've been a compliance officer, and I do have more of a finance and accounting background. That's how I got started, and started back way in the day as a Medicare cost report auditor. I'll turn it over to Steve.
Great, thank you. And I'm Steve Lokensgaard with Fagry Drinker Biddle and Reith. It's a law firm. I'm located in downtown Minneapolis, and really appreciate the partnership with Eide Bailly. I've done a number of compliance investigations over the years and different projects with Eide Bailly, and I love collaborating with them. I focus on billing compliance and fraud and abuse issues. So I'll turn it over to Rachel.
Thanks, Steve. Hello, everyone. I'm Rachel Pagliano, and I'm a senior manager at Eide Bailly, and I'm also part of the revenue cycle and compliance services area for the firm. And my background's actually more on the coding side, and I started out as a coder at an organization, but then I actually moved into a compliance role at a university health system where I was then more on the coding compliance side. But then as time went on, I was pulled into compliance projects and compliance work on a broader scale. So I still work primarily with the mid-cycle of the revenue cycle when it comes to compliance, but then I also work on other compliance type projects, whether it's with Scott and Amy or other individuals, as well as performing compliance assessments. And then I'll turn it over to Susan.
Thank you, Rachel. My name is Susan Rohde, and I am a senior manager in the healthcare division of Eide Bailly. I've been here 21 years, and my main focus is on professional coding, and within that documentation, I do a lot of studying the OIG website to see what they are currently looking at so that we can help clients if this is an issue that they may be having as well. So now I think I'm going to turn it over to Amy or Rachel. I apologize. Rachel, I think you're first. Sorry.
Yeah, no problem. All right. So some of the topics that we're going to cover today, and we're just all going to be kind of talking through some of these together, are compliance assessments and a little bit about what that process looks like. Some of the things that we typically find during a compliance assessment that might help kind of steer the ship with some directions that you might want to go and things that you might want to look at in the future. We'll also talk about evaluating the effectiveness of your compliance program and some considerations there and some things to be taking a look at. We're also going to cover telehealth and talking through some of the things that are in place during the PHE, but then what is telehealth going to look like in the post-PHE world? And then also, we know one of the things that really kind of drive a compliance officer crazy is those differences between the AMA guidance and like those CPT code guidances versus what CMS is covering or what CMS guidance is and how those things might be different. So those are just some things we're going to touch on today as we go through this presentation. All right, so I'm going to start off with some top challenges that we find with compliance assessments. So Susan, you can, yeah, there we go, to the next slide there. So one of the things with the compliance assessment process is what it's designed to do is provide an overall assessment of the organization's compliance program. And we really focus on the essential elements of the program, such as the organizational structure at the organization around compliance, the policies and procedures that might be in place, the training and education materials that are being utilized at the organization, the communications that are in place between the employees as well as the individuals there working in the compliance department, as well as the board, leadership, all of those pieces that are interconnected. Any disciplinary measures that are in place and how that is communicated and established at the organization, the auditing and monitoring functions, and then those follow-up corrective action pieces. So those are kind of like those essential elements that we cover as part of that overall assessment and really looking at what is in place regarding each one of these elements and how is that in compliance with what the OIG and other governing agencies have put forth as far as what they expect to see in a compliance program. So what the assessment typically involves is largely a review of documents that might be in place at the organization. So a lot of the things that I just mentioned are all backed up by documents, policies and procedures that are in writing, the training and educational materials, whether that's through presentations, maybe they're modules that are on, some sort of an online portal type program. So reviewing the code of conduct, the compliance program, the supporting documentation around those, looking at the annual work plan that's been devised and put in place for the organization and what they're planning to look at and review in that upcoming year, the job descriptions and how those might tie into the expectations for employees around compliance, and the compliance log. So any of those concerns or issues that might have been brought forth by an employee or other individuals affiliated with the organization, hotline calls, and then following through in those logs, well, what was the resolution or what was performed as a result of those compliance concerns that were brought forward. So in addition to actually reviewing some of those actual documents and paper information that's in place, is meeting with the compliance officer, meeting with the compliance committee as a whole, and then also meeting with leadership within the organization. And oftentimes this can also include board members that might be affiliated with the compliance committee, and also just really gaining an understanding across the organization with additional staff at all different levels at the organization on what their understanding is of compliance, and really trying to assess what their comfort level is with bringing forth a compliance concern, if they know how to reach the compliance officer, if they know how to find the hotline number, if they know where to find policies and procedures. We want to make sure that there's an understanding across the organization on compliance and how to do some of these things. So some of the top issues I would say that generally come to light during a compliance assessment is we find that organizations will fall either in one of two categories. Either they really don't have much of a program in place, and when I say that, it may mean that there really isn't any documentation to be found anywhere that really shows that there's a compliance program, or the documents that they do have in place are very outdated. Maybe they are 10, 15 years old. No one has really, dusted those off and updated them. They might be there, but really no one is doing anything with them. So it's really not current information. Or what we might see is that we've got a great program in place, and there just really needs to be some minor enhancements, some good things that can be added into the elements that are already working well for the organization and that are pretty well established. And so just maybe some minor tweaking, and like I said, just some enhancements that can be put in place for the organization. So we'll see that they've got a great backbone and they have a lot of pieces and parts that are working well. And so then we just help them along with, bringing that to the next level. One other piece that we'll find is that the board involvement is either lacking or there might be just some poor board communication. And so what I mean by that is we either don't have a board member that is on the compliance committee and really actively in touch with the compliance program that's taking place at the organization, or we might have some poor board communication, meaning that maybe it's kind of sporadic if the compliance officer attends and reports to the board on current compliance activities. Or maybe there isn't a very good dashboard or summary to outline what's happening from a compliance perspective at the organization. And so that the board doesn't really know exactly what's going on. So that piece of it could be a little bit better. What we like to see is that there is a board member that is involved in the compliance committee, and that really just connects the board with compliance and brings that piece along a little bit better. Another piece that we like to see is that there's been some board education provided on what is the board's responsibility around compliance for the organization. Sometimes we'll find that there might not really be any training materials that are specific to the board, or we find that there's no training that's been done, or we find that maybe there's training, but it's more or less handed off to the board, but there's no real expectation or follow-up to see if that training is actually performed. Another piece that we'll find is looking through that human resources collaboration with the compliance department. There is generally some overlap with some of the work that human resources performs and maybe some pieces that compliance performs. And one of those things is the job descriptions, and really outlining in each and every job description that the employees have there's an expectation around compliance and a duty for them to report compliance concerns, and that this is a part of their job no matter what position they hold at the organization. So this is oftentimes a conversation between compliance and human resources to improve or make some updates to those job descriptions. Another piece where compliance can have some influence as well is during those annual performance evaluations. And while that evaluation is going to be performed by the immediate supervisor or manager, for example, we want to see some pieces and parts within that evaluation that speak to the expectation around compliance and the individual's knowledge and understanding of the compliance program. Another great way to gain an understanding of the employee's understanding of the compliance program is during the exit interview. Oftentimes we can ask some questions upon that employee's departure on did you know that we have a compliance program? Do you know who the compliance officer is? Did you feel comfortable reporting a compliance concern? And depending on how those questions are answered, it really can help then drive maybe some changes or improvements in the compliance program going forward. So those exit interviews, it's really a great opportunity to find out some information from the employee's perspective on the compliance program. Another area that we'll look at and that we'll often find some areas for is those employee touch points, such as surveys, awareness fairs like annual compliance week, newsletters that you might be putting out on either a monthly or quarterly basis. These are all great ways to bring awareness to the compliance program on an ongoing basis throughout the year versus maybe only talking about it during an annual performance evaluation or some other opportunity. But if there's an employee survey that takes place, generally on an annual basis, inserting some questions around compliance in there is also a great way to bring that awareness forward for the employees. And as well as that compliance week. Sometimes it's just a matter of putting a table up right outside of maybe the, cafeteria area, and having some, fun things around compliance that the employees can be kind of brought into that conversation and made aware of a little bit better. One thing about policies and procedures that I'll note is that oftentimes we'll have all of the documents there for the policies and procedures. Maybe there'll be one or two things missing and that's about it. But what we found is sometimes we don't have the updated dates on those documents. So we haven't seen when was the last time it was revised or reviewed, and we're not seeing that progression on the document on that continual periodic and that consistency around updating of the documents. So just simply making sure those dates are on there is really important for the policies and procedures, as well as for the training materials, because we want to see that we're actively updating and changing training materials to accommodate for things that happen within compliance, changes that take place, and also just keeping them fresh for the employees, especially for those that, maybe they've been there for, 10, 15, 20 years. We want to be sure that we're bringing new information forward, or at least shedding light on the information in maybe a different way. And then getting back to the pre-COVID practices, I know that that's been a real challenge for a lot of organizations, specifically right now. That's really a new challenge that's come out of our compliance assessments, is they might have had things rolling along pretty well up until COVID. And then now all of a sudden there isn't the opportunity to have any in-person face-to-face time. The compliance officer isn't able to get in front of employees and do any kinds of annual trainings or new employee trainings. And so this now is an opportunity that we're opening back up to bring those trainings a little bit back into the facility, where the compliance officer can be met in person. The employees have that face-to-face interaction, which also then builds trust and comfort with the compliance officer and starts establishing a relationship with that individual, which I think is also really important for employees to feel comfort in reporting any kind of compliance concerns, or even if they're not sure if it's a concern, at least they feel like they can talk about it. So those are just some things that we found just generally over the past year or so with some of our compliance assessments. And now I'll turn it over to Amy.
Thanks, Rachel. So now that we've heard about that, some of the key components, which maybe is old news for a lot of you on the call, but it seems to be nice to have a refresher. We're going to talk about maybe something that you might not be aware of, or you may have heard of it, but that can help you in evaluation of your corporate compliance program. And so we'll go on to the next slide. There's a publication out there, or document, it's not really a publication, it's a PDF file that has the expectations of the Department of Justice, and it's from the Criminal Division, on evaluation of corporate compliance programs. And this was updated in June of 2020. And although it's really geared towards what the prosecutors and investigators should be looking at from the DOJ's perspective, they're using it more to say, okay, how did they have the key components? And we'll talk a little bit more about what their expectations are around how you can, or what they're looking for when they're assessing the effectiveness of the program. And, determining, it'll help them with if there's charges that need to be issued as around something that was perceived to be misconduct, and then to use in their negotiation pleas. And I have the link noted at the bottom of this slide that has the where this document is located. And one of the things that they will say is that, this isn't supposed to be used, it's not in a checklist format, and some things might be repeated throughout the document, but it does give you a good sense of what things you might want to be prepared for and see where you sit as an organization in it, should somebody show up and you have some documentation at least to show, and also point out areas of improvement in your program. So we'll go on to the next document. As I said, this is just basically used to help the prosecutors in their evaluation, of the corporation's compliance program, and to what extent at the time of something that might have happened that they're in there for investigating, well, how effective was the program at that time? And has something happened since to maybe mitigate some of those things? So that's what they'll be looking at. They are going to be obviously using that to look at any sort of resolution or prosecution of any, and if there should be any monetary penalties assessed, and compliance obligations contained in a corporate criminal resolution, and monitorship or reporting obligations. And we have an attorney who follows me on this discussion. I am not an attorney. I'm sounding like that, but I'm just kind of just reiterating these things that they're saying. And so what they're looking at, which I think are things that we can put into practice, are 3 fundamental questions that they're asking. And these are things you can ask yourself. Is the corporation's program well designed? The other thing that they'll be looking at is, is the program being applied, as they say, earnestly and in good faith? In other words, is it adequately resourced, and is that function empowered to work, operate effectively? And then, does the corporation's compliance program work in practice? And we'll talk more specifically what they're looking at in each one of those questions. So what we have here is the first thing: is the compliance program well designed? Now, this gets to all of the things that Rachel spoke about. It's basically the bones of your program. Do you have the key components that they're expecting to see, the policies and procedures, your risk assessment, the training? Do you have a confidential reporting structure and investigation process? And then there's something else around third-party management and mergers and acquisitions that I'll kind of explain what that is. So back to the previous slide. Thank you. So when they're looking at, well, what do they mean by third-party management? They're kind of looking at, the vendors and other partners you might have to help you do business, not just in a like revenue cycle side of things, but also just who you have in helping you from an outsourcing perspective, and what sort of business rationale was used when you were looking at this third party. Do you have a business case? I mean, I think the only time you'd have to really worry about that is if they came in and that's what they were looking at specifically. But it's something to keep in mind, because that's another thing that they will look at is your procurement process as well as your vendor management process. And then as it relates to mergers and acquisitions, it's how much involvement did your compliance program have as part of any sort of merger or acquisition? Is it well integrated, and what kind of due diligence did you perform as part of that process? So now we can move on to the next question that they want to ask yourselves is, are we adequately resourced, and does that function have the autonomy that they need to function effectively? So, the commitment comes from the top, from senior and middle management. Are they setting up that area? Do they have the right people in place or number of resources to effectively audit and assess and implement? And if it's not, individual employees, are they able to have some other resources to help them to effectively run the compliance program so that it's able to do what it needs to do? And as part of that is, what sorts, do they have the right autonomy as far as, does that compliance officer have a direct link to the board, where they're separated some from management and operations. They're able to have authority and are empowered to do things that need to be done without having to go through a bunch of channels and processes. And then the other thing that they look at is incentives and disciplinary measures. And this is where somewhat of what Rachel was speaking to around the HR function. Are we working with HR, and are we handling these things consistently across the board? We're not treating certain levels of people differently than others. And the other thing they look at is when they incentives, are we rewarding people by giving them promotions for, compliance related things and performing in an ethical manner? And are we not awarding, or are there consequences to those who might have some concerns and issues around this matter? So move on to the final question that you want to ask yourselves and evaluate is, does this program work in practice? And what they're looking at there is, do we have continuous improvement and periodic testing and review, or is it just like, oh, we did our risk assessment, that checked the box, we're done? They honestly feel that this should, in order for it to be like this living and breathing program, that we have something where we're analyzing data. And if any of you were on the webinar a few weeks ago, I talked about their expectations from and part of the DOJ and other government agencies to incorporate data analytics into your compliance program and your risk assessment. That is not a one and done. It's not a snapshot. How are you demonstrating and utilizing data as part of that? Are you monitoring KPIs and you see a spike, and then that causes you to go into another mode and maybe change direction on things? And so that's kind of what they're looking at in that regard. And from hearing what they're looking for, sometimes it's kind of nebulous to say, well, how do I know if it's effective? It's not like there's like this checklist of things. But this is one way, just by looking at your annual plan, your risk assessment, changes that you've made throughout the year and why you did that. Those are all good ways of documenting and demonstrating continuous improvement and changing courses when you need to. And then, just around the investigation of misconduct and how you go about doing that, what your process is, and consistency in that manner. And finally, analysis and remediation of any underlying misconduct. Did we learn, we found this thing, and what did we do to remedy it? Documenting that and following up to make sure it's not happening again. There should be some of that post corrective action on an item. With that, I'm going to turn it over to Steve. And I know Steve's had experience working with that document that I just spoke to. If he has anything else he wants to add, by all means, go ahead and do so. And then he can go into his telehealth considerations.
Yeah, great. I think it's a great document, Amy, for those who haven't seen it, because it's not strictly a healthcare compliance program document. It's for any type of company. And so because of that, maybe it's more readable than some of the OIG guidance documents that are specific to healthcare. And the two issues that I hadn't really thought about that much in the scope of a compliance program that were in that were the two that you focused on, the vendor management, the downstream contractors, and having some understanding of what they're doing and are they acting in a compliant manner. And then because I think that in a lot of big companies, you have the supply chain management folks deal with that, and you don't really talk about it much in the compliance world. So maybe you still have supply chain management exercising that oversight, but maybe some periodic reports to compliance to make sure we've got that base covered. And then the acquisitions and mergers issue is really important. I've seen a couple of companies get in trouble, and the DOJ said, well, when you bought this company, didn't you do some due diligence and know about these issues that they had? And so, you know, those are two issues that I don't think you typically see in the OIG compliance program guidance documents for healthcare companies, but really important to know that DOJ thinks that those are important. So we can go to the next slide. So as we talked a little bit about what some of the hot issues are going to be for next year, we thought we'd have a few slides in here on telehealth. And so the first slide here is just a reminder of how we viewed telehealth in prior to the pandemic, right? Medicare in particular defined telehealth in a very restrictive manner, only covering certain services, telehealth services provided by certain practitioners using a certain type of technology, only when the patient was at an originating site like a hospital or a clinic within a geographic area like a non-metropolitan statistical area or a rural area. So those very restrictive requirements really limited the amount of telehealth services that were provided in Medicare fee-for-service. Next slide. So during the pandemic, of course, we know that CMS expanded the list of services that could be provided by telehealth between like 140 and 150 different new CPT codes were added to the list of services that could be provided by telehealth during the public health emergency. And the technology used used to be, you know, had to be this certain interactive face-to-face technology with certain security requirements. And so that was expanded to, in some cases, a telephone would be okay to establish a telehealth visit. And the Office of Civil Rights waived some of the HIPAA security requirements so that patients could use FaceTime or Zoom to have that interactive visit, telehealth visit with a physician or other provider. The originating site requirements were waived, so the patient can now be in their own home during the public health emergency. They don't have to be in a hospital or a clinic. And the geographic area was waived also. Patients can be in urban areas or, you know, anywhere. And, you know, CMS also allowed practitioners, if it was okay with the state in which the patient was located, CMS would waive the state licensing requirements as long as they were licensed to practice in the particular state in which they were practicing. You still had to comply with state laws, but at least CMS wanted to clear the hurdles there. And so what you saw was in February of 2020, there were 105,000 telehealth visits billed to Medicare. By April of 2020, there were 8.4 million telehealth visits billed to Medicare. So these changes significantly opened the door to a greater expanded use of telehealth. Next slide. As we look at how it's going to change post-pandemic, I wanted to remind you that with respect to managed care, they've been given flexibility. Medicare Advantage organizations have been giving flexibility by Congress in 2018 to include telehealth services in their basic benefit package. And so starting in 2020, actually, it was precipitous. You started seeing Medicare Advantage plans offering telehealth services as a basic benefit. Similarly, with respect to advanced alternate payment model plans like accountable care organizations and like the next gen ACO model, they were also given flexibility to provide telehealth services above and beyond what was allowed in Medicare fee-for-service. So in both of those areas, even before the pandemic, Medicare Advantage plans and ACOs participating in certain payment models were given a lot of flexibility to provide telehealth services, and it wasn't limited to the very restrictive requirements in place in Medicare fee-for-service plans. So this is just to say that when we think about what telehealth is going to look like post-pandemic, we're really focusing on Medicare fee-for-service, because Medicare Advantage plans and ACOs can continue doing many of the things that they've been doing during the pandemic. Next slide. And of course, one thing that was a significant barrier to some telehealth services was the Ryan-Haight Act, which requires an in-person exam before prescribing controlled substances, and that was waived during the public health emergency. Next slide. So post-pandemic health, we know from the Consolidated Appropriations Act of 2022 that the telehealth waivers that were in effect during the public health emergency will continue for 151 days post-pandemic health emergency. So after the PHE expires, these waivers will continue in effect. And we also know last month, President Biden extended the public health emergency for another 60 days. So when you think of that, other 60 days into January of 2023, even if it expires at the end of January of 2023, it continues for another 151 days, so like 5 months after that. So already we're thinking about these changes don't really have to go into effect until July, August, September of 2023, but we still have to be aware of them and be prepared for them. So what's going to happen? Well, the final physician fee schedule came out within the last month, and said that for a number of services, about 2/3 of the services that were expanded during the public health emergency, providers can continue to bill for those services. There's about 111 of them through the end of 2023. And for 41 of the services, you can continue to bill for those for 151 days after the expiration of the public health emergency. So if you want to look at that list, there's a little link on the slide to look at the specific list of all the CPT codes, which ones you can continue providing for 151 days and which ones you can do through the end of the year. Next slide. So the last two slides I have here are kind of summaries of what I was just talking about. It was from a webinar presented a couple weeks ago by the Center for Connected Healthcare Policy. And if you don't know about that organization has a contract with the government to educate providers about, educate the public about the use of telehealth services and government policy with respect to telehealth services. So it's a really good site for finding out, what's happening in terms of, telehealth services. The first two columns here, we've kind of talked about. We talked about what Medicare policy was pre-COVID, what was waived during COVID. So the last slide, the last column here talks about some of the things that we mentioned here, that some of these waivers continue in effect for 151 days, like the number of services that were added continues for a period of time. The geographic waiver, like whether a patient has to be in a rural area or not, that's going to continue for the 151 days post-pandemic. But the ability to prescribe controlled substances without an in-person visit, that's going to expire when the public health emergency expires. So that could be a big change. But in the physician fee schedule, CMS did make some permanent telehealth changes, primarily with respect to mental health and substance abuse. So some of the geographic waivers remain in place permanently for certain mental health services and substance abuse services. And some services can even be provided audio only, even after the public health emergency expires. Next slide. So this is the final slide. Again, a nice little summary of the different issues like the geographic location, the physical site location, what Medicare policy is post-pandemic, and then some of the exceptions. So you'll see for the patient location being in a rural area, there are exceptions for substance use services and certain mental health services, certain end-stage renal device, ESRD services, telestroke. So there's some good exceptions that have been put in place and will continue even after the pandemic. So just wanted to familiarize you with some of those general concepts, make sure that you're watching the developments as they occur, and also point out a nice website to stay current on these issues. So with that, I'll turn it over to Susan.
Thank you so much, Steve. That was great. He did touch a little bit on the physician fee schedule, which I'm also gonna have a little bit of talk on in some of the future slides coming up. Right now, we're going to talk about the differences between CMS, which we all know is Medicare on this hand, versus the AMA, which is the American Medical Association. And that is the organization that puts out our CPT book. So all of our procedural codes, most importantly, our E&M codes, are housed there. We know that these two organizations work in conjunction on several things, especially the new E&M guidelines that came out in 2021 that were revamped in 2023 to touch on all the sections in the CPT. However, there are a few glaring differences that CMS has versus CPT, which, like Rachel said, can make you pull your hair out if you're the compliance officer, or if you're trying to do a chart review and you have all sorts of different payers. That is an obstacle to figure out, okay, are they following CMS's guidance? Do they have their own guidance? Are they following CPT's guidance? And we are going to touch on the 4 top differences, in my opinion, which are the prolonged services. The AMA or CPT, will use those interchangeably. They use codes 99417 and 99418, whereas CMS, they came up with their own codes, G2212 and G3016. Consultations, this one remains a mystery to me. The consultation codes, Medicare has not covered them or recognized them for approximately 11 years now, but every year they pop up again in the CPT book. And this year they actually tweaked some of the guidance on them, so they are still updating them. However, in my travels, I have only come across one payer that still accepts consultation codes. So like I said, this is a mystery why we keep dealing with these consultation codes. The admit and discharge on the same day. The AMA and CPT, they don't have a requirement of how many hours you need to be in. Whereas CMS, Medicare, they state that you must be in a minimum of 8 hours in order to assign the admit discharge on the same day codes. And then colonoscopies. This one is truly mind-boggling. CPT, they have their own code 45378 for a screening colonoscopy, whereas Medicare, they have G codes to use for those screening colonoscopies. The problem lies in when these screening colonoscopies turn diagnostic, we have quite a few differences, and then they trickle down into modifiers and even further down into anesthesia codes. So let's start with those prolonged service codes. Again, like I stated, CPT came up with their own codes, 99417 and 99418. CMS and the AMA were not in agreement over this due to the fact that CPT says you can start counting your time at the lowest time level in the threshold. CPT code 99215 and 99205 each have a time range assigned to them. We know that we can only assign these codes to the top level code. So it would be the 99215 and the 99205 in the office. CMS, so when you did that, the time range for say 99205 was 60 to 75 minutes. So if you add that 15 minutes onto the lowest level in the time range, which is 60, you come up with 75 minutes. Well, Medicare looked at that and they said, absolutely not. That time is still within the time range. So CMS said, we're going to let you have prolonged service, but you can't start counting the time until you have reached that top number in the time range. CMS does not recognize or pay for 99417 or 99418. They want you to use the G codes that they came up with. CMS, they're not using any published typical time for the codes, but the time in the CMS time file, which was developed by the RUC. Now this is interesting too, because the RUC works very closely with the AMA. So we kind of have all these intertwining circles coming up with policies, and they just can't seem to agree on anything. So CMS is allowing a practitioner or a provider to include time on the data visit and for 3 days after that data visit. As of right now, we are really unsure how practices are going to track that time. And again, this is not a CPT rule. This is just a Medicare rule. And this is just kind of a handy little grid that tells you the primary E&M service, what prolong code you're going to use, the time threshold, and then how you're going to count the physician or that NPP, that mid-level time spent within that time frame. And if we're going to talk about the differences for outpatient visits, again, we can only assign those prolonged codes to the top codes in that range. So for office visits, for a new patient, it would be 99205. For an established, it would be 99215. You can see the time ranges there, 60 to 74 minutes, 40 to 54 minutes. For CPT, you only need to reach 75 minutes or 55 minutes to use those add-on codes, which again is almost in the time range. For CMS, you have to meet the top number and then add on your 15 minutes. As of right now, I keep thinking that CPT will go over to what CMS states, because again, it is only 1 minute over the time range, but that has not happened yet. When we talk about consultations, again, I told you this is one of the many mysteries of the world. The 2 lowest level consults were deleted, 99241, which is the office or outpatient consultation, and 99251, which is that inpatient consultation. Those were actually deleted this year. Consultations is a service that has to be requested by another healthcare professional. It cannot be by your mom, your dad, any patient's family, or a lawyer, or a non-clinical social worker, etc. And the consultant's opinion and any services that are ordered, those have to be communicated back to the provider, either with a written report, well, only with a written report. CPT tells you to use 99242 in the office or outpatient setting, and that does include the emergency department. Quite often we do ask outside providers to come into the ED for a specialty service to see patients. And then 99252 through 255 are what we would use in the hospital inpatient setting. And now with the new regulations in 2023 that combine observation and inpatient, these would also be used at that observation level as well. And a consult is only used once per stay, per specialty, per group. Again, these were not recognized by Medicare for the past 11 years. So again, really questioning, and most payers in typical fashion followed Medicare on that consultation train. Excuse me. Medicare does not intend to change its policy on this. They still don't recognize these codes. A majority of payers did follow Medicare in this, and they also do not accept consultation codes. So again, it is a mystery why CPT keeps up with these codes. Consults do require a request from another healthcare professional, and they do have to have that written report. The concept of transfer of care has been removed from the 2023 CPT book, and that's no longer a lens in which to evaluate consults. And that's pretty big. We typically see that transfer of care if we're dealing with ophthalmologists and optometrists, where one specialty performs the cataract surgery and then transfers care to the other specialty to do some of that post-op follow-up. When we talk about admit and discharge on the same day, again, observation and inpatient have been combined into one code set. So now we have 99234 through 99236. That encompasses both an admit and a discharge from inpatient or observation on the same day. Medicare does require you to have a minimum of 8 hours. If you have less than 8 hours during that stay on the same date, they request that you use the initial codes, the 99221 through the 99223. And then in that instance, there would be no discharge code 99238 or 99239 utilized. CPT, the AMA, they do not denote a minimum time for this, so you can use 99234 through 99236 if you are strictly going by CPT rules. Again, a lot of payers will typically fall in line with what Medicare does because they don't want to recreate the wheel and come up with their own policies. It's much easier since Medicare has already laid it out for you. So you will have to contact your payers to see what their policy is on this. And then colonoscopy is, like I stated, this is probably one of the largest issues that we have when dealing with the differences between AMA and CMS. Medicare uses different procedure codes than other payers for their screening colonoscopies, and they also have their own modifiers, because why would they utilize modifiers that we already had when they could come up with their own, right? Medicare does not waive the copay or the deductible when the intent of that colonoscopy is to perform a diagnostic colonoscopy. Medicare will waive the deductible, but not the copay when a procedure is scheduled as a screening colonoscopy and then it's converted to a diagnostic colonoscopy because say they did a biopsy or they found a polyp and they snare removed it, etc. CMS has modifier P as in Paul, T as in Tom, and this really truly indicates that a colonoscopy started off as a screening, but once the provider got in there, they noticed something that they wanted to biopsy or remove, so it was converted to a diagnostic or therapeutic procedure. We would append that modifier PT to the actual colonoscopy CPT code. This is going to denote, again, that a scheduled screening colonoscopy was converted to diagnostic. Modifier PT is also added for Medicare to that anesthesia service as well. And this is going to inform Medicare, hey, this service was started off as a screening, so we don't want to charge this patient their deductible. Again, there will be a copay that is due. AMA already had their own modifier that basically stated the same thing as PT, and that's modifier 33. CPT states that if you do have a screening colonoscopy that then does convert over to a diagnostic or therapeutic, the surgeon has to document that the intent of that procedure was screening in order for the patient's insurance to process that claim without any out-of-pocket expenses. Modifier 33 specifically states, this is preventive services, when the primary purpose of the service is the delivery of an evidence-based service in accordance with the USPSTF. That's that task force in effect, and other preventive services identified in preventive services mandates. The service may be identified by adding modifier 33 to that procedure. So for example, if a surgeon is performing that screening colonoscopy on a non-Medicare patient and they find and remove a polyp with a snare, we're going to use CPT code 45385 and append modifier 33 to that to state, yes, this started off as a screening, then it turned diagnostic once I was in there. CMS screening turned diagnostic as far as anesthesia goes states to use 00811. And if you look in the CPT book, the description for this is anesthesia, lower intestinal endoscopic procedure. And we're going to want to append modifier PT to that. CPT, on the other hand, states if you have a screening turned diagnostic, you will assign anesthesia code 00812, and that's anesthesia for lower intestinal endoscopic procedure. And you'll notice screening colonoscopy is in that description. CPT is really interesting on the anesthesia because they state you can append modifier PT to that, or you can append modifier 33 on that anesthesia code. We know that CPT code 00812 says includes anesthesia services for all screening colonoscopies, irrespective of findings. So as such, many commercial payers are requiring screening colonoscopy, regardless of the findings, to be reported with this code 00812 that does contain the word screening, and only colonoscopies that are ordered for diagnostic purposes to be reported with 00811. And if that has you thoroughly confused, I did insert this handy grid that tells you if it's CPT, how to do it, and if it's CMS, how to do it, what the payer result is, and diagnosis that should be assigned or could be assigned with these. You know, also, these are not only coding requirements that are different among payers. The way that some of these claims are processed and whether or not the procedure is applied to the patient's coinsurance or deductible is also different. So this chart is really handy in showing you how the procedures are coded, billed, and processed based on both CPT and CMS. What I was alluding to earlier when Steve was talking about the physician fee schedule is hot breaking news. CMS has reduced the age to get a screening colonoscopy from age 50 to age 45. And that is to keep in accordance with that USPTF, that task force, because that was also their recommendation. They also stated within the physician fee schedule that if you are a patient and you have a positive Cologuard test, you've probably seen commercials for that. That is when you go to the provider and you get a card and you provide a stool sample. If that does come back positive prior to the physician fee schedule coming out in the CPT assistant, so the AMA rule was that's considered diagnostic. Now with the physician fee schedule for Medicare, that is considered screening. Now we have to wait and see what these other commercial payers are going to do. Are they going to follow along with CMS and say, yep, it's a screening? Or are they going to stand by what they've always stated and what's in CPT assistant that, no, this is still a diagnostic? So all sorts of things that are up in the air regarding colonoscopies, and we will just have to wait till after the first of the year to see if we get any more guidance. And with that, I can open it up to any questions, but I want to say thank you guys so much for spending your afternoon with us. And I'll turn it back over to the esteemed panel.
Thanks, everyone. I don't see any questions. We're right at the top of the hour, so I think we're going to wrap up here. Amy has a few last minute questions, or comments, one of which is to make sure, if you can, fill out your survey and give us feedback. You can see what the 2022 webinar series look like, and we appreciate those who attended. We obviously would love to have feedback on any future seminars or webinars that we put on, and we certainly would love to tailor it to your needs. So, Amy, anything else we should talk about?
No, that is it. Just thank you all so much for attending, and thank you to our awesome presenters today. We really do appreciate everyone's time. We will send up a follow-up email just in a few days here with all the information that you need. So again, thank you for attending and have a great rest of your day.